Reducing Coronary Heart Disease Deaths by me, Brandon Hange, Katie Groff, Matt Couch, and Leanne Pinegar. Our group chose the topic of reducing coronary heart disease deaths under the Healthy People 2020 objectives. Their current revised target is 103.4 deaths per 100,000, and that is reduced from their baseline of 129.22 deaths for every 100,000 cases. The objective or purpose of our presentation will be to inform our fellow classmates of coronary heart disease. This will include the pathophysiology of the condition, also complications of it and why it can be such a concern, factors that increase a person's chance of developing this condition, identifying those who are at risk and how to do so, techniques to control the condition, and also ways to decrease the mortality of coronary heart disease. Basically, we're going to be going over the primary, secondary, and tertiary prevention strategies related to coronary heart disease. Coronary heart disease, also known as coronary artery disease, is an issue of blood flow, or more accurately, an occlusion of it. Arteries that supply the blood to the heart develop fatty cholesterol deposits that form a material called plaque. These plaque sites form due to a combination of a number of different types of irritants, some examples of which are toxins from smoking, high A1C levels from uncontrolled diabetes, chronic high blood pressure, but one of the most common ones are high LDL levels, high VLDL levels, hyperlipidemia in general, combined with any type of endothelial damage. So the inner endothelial layer of the artery gets damaged, and these cholesterol or LDL molecules can start to accumulate at this damaged site because there's nice little pockets for them to fit into. This will start to attract macrophages, which will consume these molecules of LDL. They will be engorged with fat and get huge feeding off of this LDL substance, and then they'll start to die. These dying macrophages will then start to send messengers to attract more macrophages and then elicit an immune response as well, inflaming everything up. These additional macrophages will follow the path of the original one. They'll come to the site, start to eat these LDLs, die, and send out more messengers. Macrophage by macrophage, bit by bit, the original site will grow substantially inside because of the physical presence of these dead fatty macrophages. And then the artery will start to become occluded, which will decrease the essential oxygen and nutrient supply to the heart parts past this artery. This can lead to a condition called angina, which will be talked about more in depth later in the presentation. But going back to these plaque formations, they also will start to harden as they grow. And the hardened inner wall has less compliance and has a good potential for rupture because of this. When the plaque formation ruptures, it can shoot the expelled clot down to another site in the vasculature and contribute to some type of clot formation at another site. But at the actual rupture site, the body responds with massive clotting, which can completely occlude the artery. That'll cause no blood flow, no oxygens or nutrients down past it, so the heart will starve. This can lead to irreversible damage. Also, a clot from another part of the body, say a blood clot from the leg from immobility, gets dislodged. If it doesn't get stuck in the pulmonary vessels, it could become lodged in this narrow site, and that could also cause a halt in blood flow past. Some of the arteries in the heart that this commonly affects is the left anterior descending, the right coronary artery, and the left circumflex artery, among others.
Alright, now that we understand what coronary artery disease is and how it occurs, let's discuss some risk factors that contribute to the process. These risk factors can be broken down into modifiable and non-modifiable factors. Modifiable factors include diets high in fat, which correlate with elevated LDL levels in the body, causing an increased incidence of atherosclerosis and eventually possible coronary artery disease. Obesity, a sedentary lifestyle, and smoking are also modifiable factors. Smoking causes the release of neurohormones like norepinephrine and epinephrine, which increase the heart rate, increase the blood pressure, and peripheral vasoconstriction. Together, these changes cause an increase in the heart workload and in general add to the vessel inflammation and thrombosis. Hypertension is considered the second major modifiable risk factor for coronary artery disease. Hypertension is defined as a blood pressure greater than 140/90, and the stress of the elevated blood pressure causes endothelial injury on the vessel walls and therefore increases the rate of atherosclerosis. Some non-modifiable risk factors that we can't really do anything about are simply getting older. Your gender, CAD is more common in men, and in particular white men seem to be more predisposed. And of course your genes, having a family history of heart disease increases the risk of developing heart disease yourself, such as coronary artery disease. Also, your psychological state is found to contribute to your heart health. For example, type A individuals who are stressed easily or express anger are more prone to heart disease than the laid-back type B personalities. And later on, we'll discuss ways we can prevent these risk factors. So, why is identifying and correcting those risk factors important? What can come from having coronary artery disease? Well, angina is a major complication, both stable and unstable. Stable angina is chest pain that is provoked by physical exertion, stress, or emotional upset. The pain usually only lasts a few moments and subsides as exertion is decreased, or whatever caused the heart to work harder is removed. Angina is related to coronary artery disease because the fatty bulge of plaque is the cause of the reason the heart isn't getting enough oxygen, causing the pain after exertion. A little more serious, unstable angina occurs after the plaque ruptures. The body tries to correct the rupture and forms a clot that can completely occlude the vessel. This is when the patient would experience chest pain, even at rest. Obviously, heart failure is a potential complication. Coronary artery disease is actually considered the primary cause of heart failure. It is a progressive disease that results from damaged muscle, affecting the pumping mechanism of the heart. And finally, the most serious complication is considered a myocardial infarction, or an MI, which occurs because an abrupt stoppage of blood flow through a coronary artery from a thrombus caused by platelet aggregation. This can cause irreversible necrosis in the heart muscle. Cardiogenic shock is the leading cause of death after an MI. Cardiogenic shock occurs when oxygen and nutrients supplied to the heart tissues are inadequate due to the dysfunction of the heart pumping action, resulting in decreased cardiac output. The patient would present similar to a patient with decompensated heart failure. Signs and symptoms like tachycardia, hypertension, crackles in lung sounds, and possible peripheral hyperperfusion, like cyanosis, pallor, and weak pulses. Papillary muscle dysfunction or rupture may occur if the infarct area includes or is near the papillary muscle that attaches to the mitral valve. As a nurse, you'd suspect papillary muscle dysfunction if you hear a new murmur at the cardiac apex. If coronary artery disease is left untreated, the patient can also present with dysrhythmias, such as ventricular tachycardia or VTach and VFib. These complications occur in 80 to 90% of patients and can be life-threatening, so treatment is required immediately. Now we will discuss the ways in which coronary artery disease can be prevented so that these complications don't occur.
Coronary artery disease is often preventable. Prevention of coronary artery disease is largely about controlling your risk factors. Some of your risk factors could be an unhealthy diet, lack of exercise, smoking, and/or stress. Prevention should begin early in life. However, it is never too late to make lifestyle changes. Eat a healthy diet. Choose foods that are low in trans and saturated fats, sodium, and sugar. Some heart-healthy fats are included in olive oil, fish, and nuts. It is also recommended to eat more fruits, vegetables, and whole grains. Limit sweets, fried foods, processed foods, and full-fat dairy products. Also, too much sodium can raise your blood pressure as well as smoking. Thousands of chemicals are released in each puff of smoke. Simply put, just quit. Exercise is also an important piece in heart health. It is important to get more active. At least 30 minutes a day of mild exercise is recommended, or moderate aerobic exercise at least 3 times a week. You can track your workouts by using Fitbit or MyFitnessPal. As always, check with your physician before beginning a new exercise program. Stress can add to the development of coronary artery disease. It's important to learn effective ways to manage it. You can take walks, listen to music, or meditate. It is important to find something that works for you to help you relieve your stress. It is also important to learn how to read your blood pressure and know if you have any family history of heart disease so that you'll be able to be preventive and take action. Identifying coronary artery disease. When plaque builds up, it occludes our coronary arteries, which in turn decreases blood flow to the heart. Eventually, this decrease in blood flow can lead to chest pain known as angina. Angina is the most common symptom of coronary artery disease. Early signs of CAD can include sudden dizziness, lightheadedness, fatigue, nausea, and angina. A person experiencing angina can manifest signs such as shortness of breath, pressure or tightness of the chest, sweating, burning, and/or numbness. These symptoms are often mistaken for indigestion or heartburn. How is coronary artery disease diagnosed? Your cardiologist can tell you if you have coronary artery disease by performing a physical examination, discussing your symptoms, your past medical history, your social history, and your risk factors. To evaluate the extent of the disease, an EKG will be ordered, lab tests including a complete lipid profile, an echocardiogram, an exercise stress test, CT scan, and perhaps a cardiac catheterization.
Okay, so let's just say that you've never gone to the doctor and had no idea that smoking a pack a day for 20 years puts you at risk for heart disease. Or maybe your doctor keeps telling you to stop eating so much bacon and drinking so much beer and has gone over all the primary prevention stuff that we just talked about, but you just don't want to hear about it. Or maybe you've done everything right and your genes just have different plans for you, and despite it all, you've developed coronary artery disease. Hopefully you don't have a full-out infarction, but you've probably had some nasty chest pain and you went to the hospital, and now you've got all these doctors who want to talk to you about new meds and procedures and, yeah, probably about that smoking habit too. As healthcare providers, we have an arsenal of medications at our disposal to fight this disease. The aim, though, is pretty simple, and it's twofold. First, we want to fix any active problems. That includes reducing strain on the heart, and if one exists, getting rid of any clots that are posing an obstruction. Secondly, we want to prevent future events from happening, which can be accomplished partially with pharmacologic measures. The first one's a little bit more fun and a little more involved, so we'll tackle those measures first. Let's talk about our antihypertensives. Not because they're first-line drugs in this setting, but because more likely than not, our CAD patient is already going to be on some of these. ACE inhibitors and ARBs are awesome because unlike heavy hitters like low pressure, these drugs work on the systemic vasculature and leave the heart alone. Because we get systemic vasorelaxation with these meds, afterload, the force that the heart has to overcome to pump, is reduced. The heart doesn't work as hard, so it doesn't need as much oxygen, so the muscle cells can stay fed and happy. If our patient isn't on these meds yet, they will be. And more than likely, they're on them already and they're still in trouble. So we'll get into some more acute use medications. Nitrates work a little bit differently and cause direct vasodilation. This reduces stress on the heart on the other side. We're talking about preload now, and relaxes the coronary arteries as well. Because the arteries get relaxed, it's possible to restore some blood flow, which is why sometimes we can get relief of chest pain with nitro. It'll also cause a drop in blood pressure, so be careful. Generally, we want to make sure that they have a systolic BP of 100 or greater before we start giving nitro to make sure that the system can take the drop. We're also going to look at antiplatelet medications like aspirin. Baby aspirin should be on the front line of anyone having chest pain, and is probably going to be given in the field before they even get to the hospital. Aspirin is not a blood thinner, and it doesn't do anything to the clot that's formed, but it will help the clot from getting worse. It causes the platelets to be sort of slippery, letting them glide past each other instead of aggregating and forming more fibrin. Because aspirin doesn't actually do anything to the clotting cascade, the drug is relatively safe to use and there isn't a risk for bleeding unless they're taking a ton of it for no reason. Generally, we look at 325 milligrams for acute usage and 81 milligrams a day for maintenance. Of course, none of these meds will do anything to get rid of the clot, so we're talking about some invasive procedures now. We're going to go into the coronary artery and restore blood flow. By threading a guide wire through peripheral arteries into the heart and then out into the coronary vasculature, we can go in and either smash the clot, angioplasty, or go drill the clot out, atherectomy, and restore blood flow. Afterwards, a stent, a tiny mesh sleeve that expands with a balloon, will probably be placed in the artery over the lesion to keep it open and make sure there aren't further problems. These stents can even release medications that prevent tissue from forming over them to maintain patency through the life of the stent. While any procedure has its risks, prognosis here is usually pretty good and depends more on time than anything. Remember, we can't bring heart muscle back to life, but we can keep as much of it from dying as possible. Time is muscle. If worst comes to worst, we can do a bypass graft, sometimes called a cabbage, where we harvest a vessel from the patient's body and anastomose it to the coronary artery distal to the clot, restoring blood flow. Obviously, this is significantly more invasive and risky, but it may be necessary depending on the location and size of the occlusion. The risks and benefit of this procedure are outside the scope of this presentation and merit a separate lecture themselves. After circulation is restored by whatever means it takes, we're looking at more tertiary prevention strategies. How do we keep this from happening again? Well, we've already covered most of the meds. Expect a new prescription for some antihypertensives and probably a baby aspirin. If you aren't on statins, you will be now. This is a class of medications that lowers your circulating lipids and decreases the accumulation of the plaques that are the problem in the first place. Most evidence suggests that more than 70% of your cholesterol profile has nothing to do with your eating habits, so just eating Cheerios won't cut it here. Take your prescribed medications as ordered and see your doctor or provider with any questions. The other big part of this is going to be lifestyle modification. We've already driven this part home in primary prevention, but don't underestimate its importance. Diet, exercise, controlling that blood pressure, and if for some reason you still smoke after all this, giving that up, will all be important to making sure you can live your best life after this ordeal is over. So let's recap. The biggest key to preventing CAD deaths is not to let it get to CAD. This disease is significant for mortality, but it's also so preventable. As providers, we need to educate our patients until we're both sick of hearing about it. If we drive all these prevention points home to our patients, we can prevent so much damage before it even starts. Next, we need to be diligent about screening our patients for underlying disease. Blood pressure screenings are simple but effective at picking up hypertension in our populations and are an excellent place to make referrals and to educate the population. Don't underestimate the power of getting out there and teaching. Finally, remember that in the event of a cardiac emergency, rapid action is the most important intervention. EMS agencies are highly skilled at cardiac care and can initiate interventions literally minutes after making contact. Make sure our patients know not to wait to call 911. Time is muscle, and delaying recognition delays treatment. Make sure your patients know the signs of heart attacks and know to act fast. If you have any questions, please don't hesitate to leave them in the comments, and we'll try our best to get them answered. We hope this has been useful to you and helps your nursing practice. Thanks for listening.